In this lecture, we will be talking about managed care and how managed care shapes the way we offer mental health services today. To begin, let's take a little brief history tour of where we've been in terms of funding being provided for mental health services at the community level and where we are today. A good starting place when talking about mental health funding would be with the work of Dorothea Dix. Dorothea Dix was a nurse in the 1800s who, after spending time in England in the 1830s and 1840s, was witnessing firsthand the effects of the moral movement that was sweeping across Europe. The moral movement was an effort to deinstitutionalize the mentally insane, a move from taking asylums out of practice. At the time, insane asylums were used as a housing center for mentally ill patients. Treatment was not regularly provided. The intent was to just keep these individuals away from the general public. Under the direction of Philippe Pinel, the moral movement sought to increase treatment options for individuals, provide for their basic needs, clothing, food, shelter, and treatment options. As a result of these efforts, there was a noted increase in functioning and performance of those individuals that were committed to these institutions. Upon returning to the United States in the 1840s, Dorothea Dix worked tirelessly to lobby state and federal government to deinstitutionalize asylums in the United States. As a result of her efforts, deinstitutionalization was realized, and the advent of community mental health centers began. We also could look at World War II as being important for mental health funding. As a result of the war effort, the federal government invested significant amounts of time, money, and energy to promote the well-being of the American population and ensure that a strong and healthy armed forces were available for combat. Other events that help shape mental health, we could look at the formation of GAP, the Group for the Advancement of Psychiatry. This organization was founded in the 1940s by William Menninger. Menninger, along with 15 other psychiatrists, formed GAP in response to their perceived lack of understanding of current treatment approaches being promoted by the American Psychiatric Association. At the time, APA was promoting the use of electroshock therapy and convulsive therapy. Menninger and his colleagues believed that there were other options that were more humane and provided better treatment outcomes. In 1946, the National Institute of Mental Health was founded. NIMH is one of the branches of the National Institute of Health. Its goal is to promote mental health and wellness in America. The foundation of NIMH was preceded by the National Mental Health Act. The National Mental Health Act, signed into law by President Harry Truman, created federal jurisdiction for mental health treatment in America. This jurisdiction led to the foundation of national institutes such as NIMH. It also provided federal funding. That funding was used in the 1950s to conduct the Mental Health Study Act. This nationwide survey was conducted to gain a better idea of what mental health looked like in America. What were the prevalent issues? What were the pressing concerns? And how could services best be provided to meet the needs of these individuals? For the next decade, ideas were bantered about to meet the needs of the American people. And eventually in 1963, the Community Mental Health Center Act was passed into law. The Community Mental Health Center Act, as we've talked about, allowed for the formation of community mental health centers to meet the needs of the American population. Catchment areas or service regions were established in which a mental health center had to be available and certain services had to be provided for the local public. These community mental health centers largely operated the same until the 1980s, when the Omnibus Budget Reconciliation Act was passed. In this act, signed by President Ronald Reagan, federal agencies received a sweeping overview and review of their funding policies. Loopholes were closed so that budgets would become more in line with the services that they were funding. For mental health agencies, the Reconciliation Act led to the use of block grants. A block grant represents a new form of funding for these community mental health center agencies. A block grant is a large sum of federal money provided to a community mental health center with very little direction or oversight as to how the money should be spent. Rather than a line item budget, the institution or center itself was allowed to decide how the money should best be allocated and used. So what does funding look like for mental health treatment today? Unfortunately, both federal and state budgets for mental health services have dropped. As economic times harden and financing budgets becomes more and more difficult, mental health services are often one of the first to be cut. By way of comparison, in 2006, the average level of state funding for mental health was $30 billion, which is less than 12% of what it was 50 years ago. Today, the largest source of funding for mental health is Medicaid. Medicaid accounts for over 52% of mental health budgets nationwide. So very few dollars are actually coming from the government directly for mental health services. So let's talk a moment about Medicaid and Medicare two federal programs that play a large role in funding mental health care. Medicare is available to persons over the age of 65 who are eligible for Social Security. It also is available for persons under the age of 65 with a specified disability. The percentage of Medicare dollars expended on mental health care is actually quite low. The majority of Medicare dollars are spent on medical care, both acute and long-term. Medicaid is the program that provides funding for the indigent, those who are below a certain threshold based on their finances and income, who are unable to afford services. Approximately 15% of all Medicaid dollars are spent on mental illness or mental health treatment. The number of Medicaid claims, both for mental health and medical treatment, is higher for mentally ill clients than it is for non-mentally ill clients. So clearly, the use and availability of Medicaid funding is significant for mental health providers. Today, we see changes going on that can again affect funding and availability of funds for potential mental health clients. Under the Patient Protection and Affordable Care Act, which President Obama has signed into law, the Medicaid program would be expanded. By expanding Medicaid, a greater number of individuals would now be able to access services that previously they were not able to do. How would the program be expanded? Well, the definitions would change for who is eligible for Medicaid coverage. Medicaid will now be available for individuals whose income is no greater than 138% of the federal poverty level. Initially, the federal government is picking up the cost of this program. Until 2016, the federal government will pay 100% of all costs associated with expanding Medicaid. Beginning in 2016 and carrying through 2022, a cost-sharing plan would be put in place, with the federal government picking up 90% of the costs and individual states having to contribute 10% of the costs. For many states where budgets are already tight and stretched beyond reason, adding the expenses to cover this 10% is going to be quite the challenge. In addition to these federal funds, private agencies also are playing a role in mental health care funding. We see the advent of managed care becoming a big part of health care and mental health care. Up until the 1970s, health care was guided by two main principles. These principles are that the doctor knows best, and we must spend whatever is necessary. In these days, doctors were given carte blanche. They were the experts in their field, and if this is what they deemed necessary treatment, that's what was funded. Unfortunately, this practice led to healthcare budgets spiraling out of control. In 1965, healthcare expenditures in this country were over $42 billion annually. In 1985, only 20 years later, healthcare expenditures were 10 times as much, topping $445 billion. In 1992, that number nearly doubled, as healthcare expenditures were now over $800 billion. And in 2010, some of our most recent estimates, healthcare expenditures were over $2.6 trillion. Clearly, a change needs to be made as these numbers continue to grow. So what is managed care? Well, managed care was established in the 1970s as a way to control costs. Initially, these health insurance plans were established as a fee-for-service system, where individuals who were covered under a managed care program received a discount for services rendered by participating providers. This process is similar to discount cards you get at local supermarkets or department stores. Initially, these health insurance plans only dealt with physical health concerns. It wasn't until the 1950s that mental health and substance abuse services were added. Because of rising costs, the way that managed care and health insurance companies charged for services changed. In 1973, the Health Maintenance Organization Act was passed by President Nixon. This act provided for the creation of health maintenance organizations. Federal dollars were made available to help agencies begin services and market these services to various companies and organizations. In the 1980s, we see several managed care companies emerge. Competing companies allowed for prices to be contained in a competitive marketplace. More and more managed care companies were including mental health services. However, the formularies used to derive costs and member copays for managed care when it comes to mental health services were different than what they were for regular health services. It was not until 1996, when the Mental Health Parity Act was passed, that managed care companies were forced to provide equal services for both health and mental health issues. So what is managed care? It's a system that companies and organizations use to provide financing and delivery of health services to their employees. these organizations contract with providers to offer reduced rates and discounted services to their members. In exchange for offering these discounted rates, providers were essentially guaranteed a steady client base. These managed care companies grew in popularity in the early 1980s. They became a major perk or fringe benefit that companies were able to offer to prospective employees. Initially, managed care companies were met with great favor. They were seen as a way for employers to manage costs. In the previous models, fee-for-service models, full cost was paid for services. Now, costs were reduced at discounted rates. The individual providers and insurers were expecting more of the risk associated with providing health care. It was the company that would pay the insurer. The insurer then worked with the providers to determine appropriate level of care, treatment needed, and how to best manage available funds. The overriding assumption of managed care is that if you keep healthy, you reduce your costs. The less people accessing services, the less premiums that you pay. Managed care companies also work under the assumption of giving people what they need, not what they want. Selecting services that are the most affordable and economical, rather than just allowing people to have whatever it is that they want. And thirdly, managed care companies made both providers and patients aware of the cost. Once you see the cost, sticker shock hopefully sets in. When you realize how much services cost, the idea is that you will be more fiscally responsible and prudent with your use of services. If every time you had to go to the doctor, you had to pay completely out of pocket for that doctor, you may be less likely to go and try some at-home remedies first in the future. So the purpose of managed care is twofold. The goal of all of these companies is to ensure quality of care. Make sure that the services provided to clients are of high quality and they are effective. Second is the containment of costs. To try as best as possible to prevent this exponential increase in healthcare expenditures. To do this, there are some formulas put into play. First, managed care companies look at total cost. Total cost is derived by utilization times the cost per unit. For example, if it costs $30 per session to fund a counselor, they would multiply that by how many sessions clients saw that counselor for. If I, as a client, saw a counselor for 8 sessions, the total cost of my treatment would be $240. 8 sessions times $30. They then look at the value. The value is derived by taking the desired outcome minus the adverse outcome and dividing it by cost. So what is the desired outcome? It's what we hope happens. A person achieving health, a person getting better, minus the adverse outcomes. What are the unexpected outcomes? What are the potential pitfalls or challenges? So in theory, if the good outweighs the bad, it's considered a value. If the difference between the good and the bad is very small, there's only a small chance of success, then it's not a very good value. Some of the characteristics of managed care funding and program operation. Authorizations are required. Before an individual could seek services, they may either have to get a referral from their family care physician or primary doctor, or they may have to call the insurance company and have an authorization issued to allow for services to be billed. This authorization may need to be initiated by the client or the provider. In some cases, second opinions are required. Cases are reviewed. A process known as utilization review is in place at most mental health agencies. A utilization review specialist works with the treatment providers to get daily and weekly updates on client progress, and that information is communicated to the managed care companies. That information is used to determine whether additional sessions or treatment options are needed, or if a client may be able to transition to a lower level of care. To assist in the case reviews, treatment plans are becoming a common factor in client records. Treatment teams get together and fully document what it is they're working on with their clients. Clear goals are established, and objectives are put in place to help meet those goals. By using treatment plans, services become more streamlined. Those services provided to the client are directly related to the goals established for that client. Within the managed care field, there are several different types of organizations. One is the Health Maintenance Organization, HMO. These were the initial managed care companies. An HMO is characterized by a defined comprehensive benefit plan financed on a prepaid per capita basis. Your organization or company that you work for contracts with an HMO to provide your health and mental health care. They arrange with the providers, the doctors, counselors, psychiatrists, on a rate plan. These providers are prepaid on a per capita basis. So an organization, let's say a mental health center, may tell the insurance company that we will see people for psychiatric evaluations for $50 a session, and we will do counseling at $30 a session. The organization then pays these services as its employees seek them. Now the challenge with HMOs are, as an employee, you have to see a designated provider. Options are not made available to you. You are given a list of who the approved providers are for your organization. And prior to seeing any specialists or mental health professionals, you have to see your primary care physician and get a referral. For some organizations, the logistics of the HMO plans became cumbersome, so other options emerged. PPO plans became popular in the mid-1990s. A PPO plan is a provider organization. The term preferred is to your benefit. You now have the option of deciding who you go to see. Two fee structures are established, one for in-network providers and one for out-of-network providers. Should you choose to see an in-network provider, your out-of-pocket expenses are less than if you go see an out-of-network provider. PPO plans also saw the advent of the copay. Clients were only responsible for paying a small percentage of the services up front when services were rendered. Another advantage of the PPO plan is that doctor referral is no longer needed. So if you chose to go see a specialist, you did not need to get a referral from your primary care physician. Operating these PPO plans are third-party administrators. These were individuals contracted to help determine best level of care needed for individual clients. Providers would call and speak with an authorization specialist who took information about the client's presenting issues, signs and symptoms, and helped to determine what would be the appropriate level of care for that individual. We've talked about employee assistance programs becoming popular. These are a form of managed care specific for an organization in which the organization hires a provider or contracts with an outside provider to provide mental health care specifically for their employees on a short-term acute basis. There also exists IPA practice. An IPA is an independent practitioner association. These are groups of providers doctors, nurses, counselors, psychiatrists, who form a collective practice in which they agree to offer services at a reduced rate for their clients. The benefit of these practices is local availability of health providers and a continuity of care, as the different providers you're seeing all are working in concert with one another. And finally, another term you may hear is capitation. Capitation is a funding method that managed care companies use. Under a capitation plan, a certain amount of funds are allocated for each employee. Those funds are then used to pay for certain services that person may seek. Organizations pay this fee per employee, regardless of whether or not the individual seeks treatment or not. So it's a negotiated, prepaid benefit. For example, a managed care company may contract with a business and say, we will offer mental health services to your employees at a rate of $1,200 per year per employee. The company would then pay $1,200 per employee to the managed care provider. The managed care provider is assuming some risk here. Should all the employees need severe mental health treatment and continual services, they'll actually lose money. What they bank on is the fact that many people may not access services at all. It's the same principle that insurance companies work on for your car or your home. Although paying claims for accidents, repairs, damages, injuries are quite expensive, the actual number of people filing claims. So how do managed care companies influence our work as counselors? For one, it has a say on the types of treatment that we provide. Under managed care policies, brief therapy is the preferred model. Getting clients to an optimal level of functioning in as few sessions as possible is a goal. In addition, evidence-based practice becomes a necessity. What we do with our clients needs to be documented. We need to show that there is a research base supporting the techniques and interventions we use. We need to be more pragmatic in our work with clients. Identifying a problem, working specifically on that problem, and not deviating much from that plan. Counselors may find themselves communicating with primary care physicians on a more regular basis, updating them on what is going on in therapy, and having to make sure that we keep excellent records in terms of case notes, treatment plans, progress updates. All this information is shared with a managed care organization that is evaluating the services the client receives and determining what will be funded. To effectively work in a managed care organization, you need to be business savvy. Realize that managed care companies are in business to make money. While our goal is to help our clients, and we have a more altruistic, humanistic approach, these organizations are set up as for-profit businesses. Having a good working knowledge of the DSM, managed care companies fund for services that are designed to treat illnesses that are documented in the DSM. Learning how to write treatment plans that have clearly written goals and objectives. Keeping good records so that billing can be straightened out. Using brief therapy techniques. Making sure that the practices and interventions you use represent the best and latest in the field. Reviewing the current literature to see what is supported in research would be important. And finally, being able to work well in a team environment. Treatment teams play a large role in managed care work. So what are the advantages of a managed care organization? Well, they contain costs. As the amount of healthcare dollars now numbers in the trillions of dollars, there needs to be containment of costs. But at the same time, quality cannot be compromised. Individuals should not be at risk for inferior care, all to save money. Managed care also increases access to services. By only having to pay a copay up front, individuals are now able to get the help that they need when they need it most. Because organizations are all working with these managed care companies, concise standards of practice are in place. There will be a continuity of care or some type of standardization across providers. For the provider, there are increased referrals. Participating in a managed care organization gives you greater access to potential clients. For clients, there may be increased motivation to get help. Knowing that it's available at an affordable rate may be the motivation they need. Some disadvantages. There are those that believe that standardized treatment plans neglect individual differences. Having to use a template for each client goes against many of the basic principles that we have as counselors in terms of treating clients as unique individuals and addressing their problems and concerns as they experience them. In some cases, your clinical judgment is usurped. You may deem that this client needs inpatient treatment. The managed care authorization specialist may decide otherwise, and thus inpatient treatment will not be funded. Managed care also places arbitrary time limits. That same authorization specialist may authorize 5 sessions or 8 sessions. And so now you as a counselor need to work within those parameters and make sure that you're maximizing your time in those 5, 8, or however many sessions granted. There's increased paperwork. Many counselors complain that there's already not enough time in the day to see clients and complete paperwork. Adding managed care paperwork only exacerbates the problem. There's difficulty in being added to panels. For some insurance companies, they may have already reached a saturation point where they already are contracted with enough providers of a certain type of service in an area. As a new counselor, you may find it difficult to get on these panels, and as a result, your ability to work with clients who have those insurance plans is minimized. And then finally, the structure of the managed care organization. Keep in mind that these organizations are designed to be for-profit companies. And sometimes you will have differences with them in terms of what you think is the most appropriate level of care for a client. Being able to learn how to avoid frustration in times like these will be important to you as a counselor. So as you work with these companies, keep in mind that they're designed on a medical model approach to treatment. The medical model looks at identifying a problem, labeling it, and treating it. This is why it's important for you to become familiar with the DSM, because counselors will need to label what it is, the pathology they're seeing, before treatment can be authorized. Knowing the diagnosis and the DSM code for that diagnosis is important. Knowing that services have to be tied to the goal of treatment and must be medically necessary. When it comes to substance abuse treatment, detox programs or inpatient treatments are not authorized for individuals wanting to come off of all alcohol or drugs. A detox program is only necessary for individuals who have been using and abusing a substance which has a medical risk when withdrawal sets in. There are not detox programs for marijuana or cocaine use. And the types of counseling you use have to be approved methods. As I mentioned, brief therapy is particularly suggested in working with managed care clients. In addition, cognitive behavioral therapy and dialectic behavior therapy, two approaches that have strong research support for them, are accepted by managed care programs. Working with a managed care company also requires you to think about how it affects your work with clients in an ethical manner. You may find some dilemmas, both personally and professionally, in several areas, including client welfare. You believe a client needs to be at a certain level of care. The managed care company deems otherwise. Confidentiality may be compromised. Information now needs to be shared with another level in terms of the authorization specialist, the managed care company itself, and sometimes the employer. With all of these added sources and people who need access to client information, informed consent becomes important. And finally, your competence or integrity may seem to be under attack. Keep in mind that these insurance companies are not trying to undermine you or discredit your competence. They're simply operating under a different mindset, one in which their goal is to contain costs. And so finally, is managed care the right environment for you to work in? There are some providers who opt not to accept insurance payments. They only operate on a out-of-pocket, cash-for-service basis. So as you begin your career, you may want to consider if managed care options are the right choice for you. Are you able to work in a situation where you are going to be dictated how many sessions you could provide a client and what services you're allowed to do? Is funding an issue where you need the increased referrals and guaranteed client base? Or are you able to operate on a cash-for-service basis? Is someone available to do your utilization review? Or is this a job that you too will have to take on? If so, keep in mind that this will limit the amount of actual client interaction time that you have in a given day. And how is your organization financed? If you start a private practice and are relying on income from clients, you may be challenged by some managed care companies. For some, it may be weeks up to a month or two before you're reimbursed for services provided. When just starting out and barely making ends meet, waiting on funding can be quite problematic. Taking into consideration all the benefits and the challenges together, we need to realize that managed care is certainly here to stay. While it's constantly changing and updating, it is going to become the model which all counselors will eventually have to work under. The more you become familiar with what needs to be done to satisfy managed care company policies and procedures, the more effective you'll be in working with your clients.